Rituja? So Dr. Rituja has requested to go first. So Dr. Rituja Thomas is going to talk about orbit and oculoplasty from science fiction to or AI enhanced orbital surgery. So she'll be going first, then we'll start following the order with Karthik Mahalingam next. Over to you, Dr. Rituja, for this impact of artificial intelligence in various subspecialty sessions, starting with orbit.
Thank you very much, Dr. Prasanna, and happy to be here today. So, in orbit surgery, there are various nuances, but this has happened mainly because of various changes that have taken place with respect to innovating based on what you find in the orbit. Now, for example, in an orbital fracture, if you have a simple single wall fracture, what we do is we go through the transconjunctival approach, and we can put a simple PTFE implant or a biopore implant. And for example, this is how you isolate the fracture site. And once you've got all the contents out of the fracture and make sure that there is no impingement of any muscles or tissue within the fracture site, you can go ahead and place the implant. And it's very simple, nothing AI about this. Now, with two wall fractures, it's best to use something called a titanium plate, which is preformed. So it comes like this. There's nothing, again, AI or customized about this. It comes in the set based on which side you want to do, whether it's a right eye fracture or a left eye fracture. And you can go ahead and place the implant in these models, which you can order earlier. And it gives a very good result. Now, for example, in this patient who has enophthalmos, this is the CT scan showing the floor fracture, which is already healed. And now you can see after putting the titanium implant, how it bridges the floor as well as the medial wall. And post-operatively, you can see the improvement in the enophthalmos. Now, for very large orbital fractures with downward displacement of contents and total loss of orbital floor segments in some cases, you'll have a very significant facial deformity. So here comes the role of patient-specific implants. So you can see in this, there is a post-traumatic enophthalmos which is significant, involving multiple bones, and this usually needs the help of a maxillofacial surgeon also to form the zygomatic structures in the original position. So when all these things are being replaced, we can sort of go ahead and put in the preformed implant. So this is a 3D modeling done with the DICOM images of the patient mirroring the normal eye, okay? And this 3D printed peak implant or polyether ketone can be put in the fracture site. So the only disadvantage of this is you need a wide exposure in order to be able to place the implant. Once the implant is placed, you fix it with screws as you would fix it for titanium implants, and then you get a good replacement of volume in the area where there is enophthalmos. Now, similarly in this patient, she had a similar issue, but you can also 3D print the titanium implant. So it's not just for the peak implant. And you can use these models before surgery, which are printed again based on the patient's DICOM images. So this is the pre and post-operative appearance. Now the advantage of 3D printed implants and patient-specific implants is you can measure the volume change, you can mirror the normal side or the fellow orbit, you can get better pre-operative planning and a precise contour match. And the good thing about this particular peak implant is that it has a very good biocompatibility and it's a convenient manufacturing process. For example, you tell the person to manufacture it, he will send it to you within about 3 days. Now the limitation is, of course, that there is some amount of learning curve. Like I mentioned, you have to get a wide exposure and you have to be able to place it properly. And if the implant isn't suitable in some way, in some part of the structure, you have to sort of try and modify it, which is not possible with a titanium implant. Now, this is how we see the model before putting the implant for the patient. This is what the company sends you, and based on this, you can decide what modifications need to be made before you actually go ahead and put. So for example, if this looks too long posteriorly for you, if it looks like it will go too far behind, you won't be able to place it, you can make it a shorter implant. Now, with respect to orbital decompression, so this is another thing into which stereotactic navigation has come in, and these are the various approaches for orbital decompression. So what happens with navigational surgery or real-time imaging along with surgery is that it improves the strabismus outcome. So you won't require, less patients will require strabismus surgery after getting a decompression, and it also decreases the surgical time, and it helps you remove bone more aggressively because you have an idea of where you are actually. And the only issue with this is that a navigation system is very expensive. So it's usually shared between 3 or 4 centers. And after this, orbital implants which we place, for example, for patients who are undergoing a dermis fat graft, instead of that, if you can actually put in a customized implant, it will actually reduce the migration chances. And after a decompression surgery, there is now quantitative assessment with stereo imaging to see how the patient's facial contours have changed after surgery. And you can see based on each wall decompression how the change in contour takes place. Now, with respect to endoscopic orbital decompression, again, this is another thing which is very specific, and it's very helpful in compressive optic neuropathy cases in thyroid eye disease. And this, again, when done specifically, helps well. And finally, custom-made ocular prosthesis is definitely a thing which all ocularists are doing these days, but people have found a way to sort of semi-automate the fabrication of this and improve the time in which it is made. Because, for example, if someone from another city visits a ocularist and requires an implant, they usually are there for maximum 48 hours. So if this can be improved, the timing can be improved, it can be done in one day and they can get an implant and leave the next day. So thank you very much. This was all about AI and orbital surgery, and I hope it was interesting and different.
Thank you, Rituja, for finishing in 6 minutes, I think, well on time. Digvijay sir, your comments on the talk, sir?
Yes. So a lot of this is already what is now underway, happening, right? And what is kind of the how does the costing vary? Let's say these implants that you get customized. I mean, is that adding to the
Yes, yes. So the customization or 3D printing adds to the cost significantly. So for example, if you are using something like an EPTFE implant for a simple floor fracture, or using 2 implants for a floor and a medial wall fracture, that would hardly add to the cost by 2,000-3,000 rupees. But if you have a preformed titanium plate, that would be around 20,000 rupees extra. And if you have a 3D printed or 3D printed PEEK implant or titanium implant, that would be about triple the cost with respect to the implant cost. The surgery cost would remain the same.
there are specific indications where one can look at this rather
Yes.
than
So
because
like I was showing, if it's a simple 1 wall or 2 wall fracture, you don't need to go in for this. But patients who have zygomatic wall fractures and severe enophthalmos because of multiple bone fractures and multiple loss of segments of the orbit, that's where we would require it. Thank you.
Thank you.